Well, good morning, everybody, and welcome to those that are joining us on YouTube. It's my real pleasure this morning to introduce a good friend and colleague, Dr. Krish Sathian. Krish is the chair of the Department of Neurology and the world's recognized expert in the area of cognitive medicine, cognitive decline, dementia. And it's a real great opportunity to have Krish joining us this morning. So Krish, welcome.
Thank you, Jim. Can everybody hear me? Good?
Yeah.
All right. So thanks for inviting me, and thank you all for having me. It's obviously a very important topic to all of us, age-related cognitive decline, particularly topical with some of the things that are going on in the news. But you know, even for youngsters, I mean, it's important because you know probably everybody's got a parent or a relative who's maybe experiencing this or on the verge of experiencing this. So I'm going to talk a little bit about you know, the diagnostic considerations. There'll be some technical terms, but I'm really going to try to keep it light on the jargon. But please feel free to interrupt me if I say anything that's not clear, so we can clarify as we go along. And then probably I have a slide that's probably the most important slide that I'm going to talk about, which is how to prevent age-related cognitive decline. Those are my disclosures. None of them are really relevant to this talk. I did have a book chapter related to from the you know in both those book chapters for the edited books relate to age-related cognitive decline in some way, but there's no sort of commercial interest here. So when we talk about cognitive decline, we often talk about this entity called mild cognitive impairment. It's abbreviated as shown here, MCI. And MCI is really sort of an operational definition. It's not a formal diagnosis, but it's kind of like a holding pattern state, if you will. What is mild cognitive impairment? To the neurologist or psychiatrist who's evaluating a patient or a geriatrician or your family doctor, mild cognitive impairment implies subjective complaints of significant cognitive problems. For example, memory loss. I'm going to stop for a moment there because people often get concerned, oh, I forgot something here. Do I have mild cognitive impairment? Not really. If you just forget something here, something there, that's normal. We have so many things that we have to remember. Forgetting is actually important for the brain because there's no way we can remember every single fact and incident in our life, right? So forgetting is important so that our memory is ready to hold new information. But if those problems with memory or other issues impact your everyday life, that's when we consider it significant, and that's some of the judgment that your physician is going to exercise or your neuropsychologist is going to exercise in talking to you or your family member to try to decide if this is significant or not. In addition to those subjective complaints, that's what the patient experiences or the family reports, there's also got to be objective evidence of cognitive deficits. That is, we do tests in the office. These could be paper and pencil tests, or they could be tests on a computer, but the tests have scores, and we try to determine from these tests if there's objective evidence of cognitive deficits. That is, does the person score below expectations? And we have like statistical norms for all these tests and so on and so forth. And finally, in order to diagnose mild cognitive impairment, we also have to have intact activities of daily living. That is, the person is able to engage in all their normal daily activities. Even though they might have some memory loss, they can still function, they can drive, they can manage their finances, they can pay their bills, perhaps with some reminders or auto pay, things like that. Now, that's to be distinguished, mild cognitive impairment can be divided into what we call single domain, because our cognitive functions can be divided into many different domains. For example, the domain could be memory, And if there's only memory trouble and there's no trouble with anything else, and on objective testing, the deficits are found only in the memory domain, we call that single domain MCI. For example, it could be amnestic MCI, which means memory is the only problem. Or when it begins to progress, it could be multi-domain. So it could involve multiple cognitive domains. For example, you might have trouble with memory. You might also have trouble with what we call executive function. So the brain's got an executive control circuit that is responsible for tasks such as organizing your daily schedule, organizing the tasks that you have to do, how do you sequence the tasks. And these could be just your schedule for the day, or if you're going to prepare your breakfast, how do you sequence tasks in the appropriate sequence in an efficient manner. Multitasking, all these are under the rubric of executive function. And there are many other cognitive domains. So you can have MCI that's single domain, or it could be multi-domain. And MCI is important to recognize. As I said, it's kind of like a holding pattern state because MCI, the most important thing, the reason why it's important is because it could worsen and move into dementia. And we're going to talk about what dementia is in a second. Sometimes MCI might just stay MCI, might be static, might not progress at all. And occasionally, MCI might actually revert to normal. You might have a diagnosis of MCI, but it might actually get better. For example, there might have been some incident, maybe a psychological trauma, maybe some depression, things like that, that caused the patient to be impaired in terms of reporting symptoms as well as in terms of testing, but those things dissipate and you could actually come back to normal, which is why we need to sort of formally follow people on a regular basis. Is everything clear so far? Am I at the right level? Okay. Any questions? Like I said, please feel free to interrupt and ask questions. Okay, now what's dementia? So dementia is worse than mild cognitive impairment. Dementia is not a single disorder. It's what we in medicine call a syndrome. That is, it's just a collection of signs and symptoms that we sort of put together. It can be caused by a variety of diseases, and we'll see in a moment what some of those diseases are. But we define dementia when a person has cognitive impairment in at least two domains. Like we just talked about multi-domain MCI, you've got to have at least two domains. For example, you could have memory and executive function, or memory and language, or executive function and language, and there are many other cognitive domains. But you've got to have impairment in at least two domains, and the impairment's got to be severe enough to affect the activities of daily living, the ADLs. Okay, so that's when we diagnose dementia. So I talked about MCI earlier, and many people with MCI do progress to dementia. In at least the most common forms of MCI associated with Alzheimer's, which we'll talk about in a moment, we have a sort of an average holding state for about 4 years in the MCI phase. And one of the reasons why people have been very interested in identifying people at the stage of MCI is, as we'll see in a moment, there's a cascade of events in the pathology of the brain with all these neurodegenerative diseases. And the thinking is that the earlier we can catch you, the more likely we will be able to provide effective treatment. That's the goal. There are a variety of diseases that cause dementia, okay? So people often ask, what's the difference between dementia and Alzheimer's? So this is the difference. Dementia, as I said, anybody who has this collection of things is said to have dementia. But that dementia could be caused by a variety of specific neurological disorders, of which worldwide, the most common is Alzheimer's disease. The second most common is what we call vascular dementia. That is due to, problems with the blood vessels in the brain. So either one of the big blood vessels gets blocked and you have a stroke, or you have, more commonly, a lot of the tiny blood vessels around the brain get blockages. We call this microvascular disease, and that can cause vascular dementia. So then in this case, there's not a formal diagnosis of a stroke, but people just begin to get impaired in their cognitive function and sometimes the motor function as well. And then there's really a laundry list of various other neurological disorders which are less common that can also cause dementia. Frontotemporal dementia, or FTD, you may have heard about, Lewy body dementia, corticobasal ganglionic degeneration, getting a little esoteric here, progressive supranuclear palsy. You don't have to obviously remember all these things. There's not going to be a test, right? Prion diseases are, they're rare, but they are transmissible diseases. They're the only form of these diseases that are actually transmissible between individuals. You may have heard of Creutzfeldt-Jakob disease, mad cow disease, scrapie in sheep. And then this entity that is becoming increasingly recognized called chronic traumatic encephalopathy, or CTE. Used to be known as dementia pugilistica, was reported in people who had who were boxers. Towards the end of their life, they developed dementia. That was called dementia pugilistica. It's now been recognized in particularly NFL football players. And basically, any individual who's subject to repetitive, high velocity, high impact hits to the head multiple times over is susceptible to potential chronic traumatic encephalopathy. We still don't have a good understanding of what the frequency of this is relative to the number of people who are involved in, for example, playing football or boxing. So those are some of the specific diseases that cause dementia. But again, by and large, Alzheimer's is the most common, vascular dementia is the second most common. So when you see a neurologist or another specialist, what they're trying to do is they're trying to determine which of these disorders might be causing the problems that you're experiencing. One of the complications with that is that when people come to autopsy, when we actually examine the brain after death, we find that multiple pathologies are often present. In fact, in about 80% of people, there are multiple pathologies. So the brain, the person might have presented in life as having Alzheimer's disease, and that might have been the clinical diagnosis. But at pathology, they might have evidence of Alzheimer's disease. They might also have evidence of vascular disease significant enough to be consistent with vascular dementia. And sometimes they even have multiple other things, Alzheimer's and Lewy body, Alzheimer's and frontotemporal dementia. So it can be difficult to actually make a specific diagnosis in life of which of these diseases is causing the dementia, or for that matter, the mild cognitive impairment you're being seen at that stage. Okay? And so that's important to understand. One of the problems here is that it's a bit of a catch-22, because when you see the neurologist at this point in time, at least until a few years ago, there wasn't a lot of motivation to try to find out which of these specific diseases was involved, other than vascular disease, which we can diagnose pretty well from an MRI. The reason for that is there wasn't really any specific treatment. So why bother? You could do some testing, you could do some research, you could try to figure it out, but at the end of it, if you're not going to be able to offer a specific treatment, you might wonder what's the point. So we're just moving beyond that, and I'll show you where this is going really in the field of Alzheimer's disease. That's where the most progress has been made. This is a little bit technical, but most of the pathologies, pretty much in all these diseases, involve what are called misfolded proteins. So there are a lot of proteins in the cells. And the proteins in the cells are not just like linear structures, but they kind of fold on each other. They have what are called tertiary and quaternary folds. And what happens in these disorders, for reasons that are still mysterious, is that these proteins start misfolding. And then they clump. When they misfold, they clump. If a normal protein in its normal structure can be cleared from the cell, but when it clumps, it sort of clogs up the works, as it were, and so it can't be cleared. And then what happens is the tendency to form those misfolded proteins somehow gets transmitted from cell to cell. So if neurons in one region are connected to neurons in another region, this is what forms neural networks. That's how our brain actually functions, because it's not just one part of the brain that's doing one function, but it's like massive neural network. So it spreads along that neural network. This tendency to form the pathology spreads along the neural network. So that's why these diseases progress. So for example, in Alzheimer's disease, the earliest signs of this pathology might be in what we call the medial temporal lobe, kind of like an inner part of the brain. And then it spreads from there to the lateral temporal lobe, which is the sort of immediate connection. And then it spreads to other regions like the frontal lobe and the parietal lobe, and last of all, the occipital lobe. So it really follows along those connections. And that's why there's a sort of a very systematic progression. And the pattern of that progression tends to be different in these different diseases. So this is a graph that illustrates our current thinking about the pathology of Alzheimer's disease. So, as I said, we have this entity called MCI, mild cognitive impairment. And obviously, before you get into mild cognitive impairment, you're cognitively normal. Then you go through the stage of MCI, and as I said, you might progress onto dementia. So, what happens is, if you look at a number of different things in the brain, as I said, there are misfolded proteins, and there are two bad proteins that misfold in Alzheimer's disease. One of them is called amyloid, and the other is called tau. That's a Greek letter tau, and it's just called that, T-A-U. So, what seems to happen, and this is, we don't have proof of this, but this is what is called the amyloid cascade hypothesis. So the idea here is that amyloid is beginning to deposit in the brain at a very early age. So if you develop, let's say if you're going to develop MCI at the age of 65, this amyloid is probably depositing in your brain even in the 40s. And then it's sort of accumulating progressively. You can see this, what we call a sigmoid curve. And then at some point it crosses a threshold. And meantime, in some way that we don't understand, this accumulation of amyloid triggers the accumulation of this second protein called tau. You can see that here you have a curve that looks more or less similar to that, but it's lagging it. So it's following it in time. So you can see that for that to reach a so-called critical level is going to take a little longer. And then ultimately, these two proteins interact in some way, and then they cause the neurons to actually start dying. That's what we call neurodegeneration. And we have a number of different tests. This has been studied now for a long time in humans, as well as in a variety of animal models and cell cultures and so on and so forth. And we have developed tests. The community has developed tests for some of these, for each of these different phases. So amyloid can be detected now in the brain by spinal tap. We can do a spinal tap, extract a few milliliters of cerebral spinal fluid, and we can examine that for biomarkers. So you can detect amyloid, and particularly the bad form of amyloid, which is called amyloid beta. That's a misfolded form. So when it misfolds, it actually spills into the spinal fluid, and we can pick it up there. We can also detect it by imaging, a special kind of scan called a PET scan, positron emission tomography scanning, in which we have a tracer for amyloid. So we can detect it either by amyloid imaging or by spinal fluid. For tau, we can also detect tau in the spinal fluid. And then there's some indirect measures that I'm not going to go into. At the moment, that indirect measure has been supplanted by actually tau imaging. We can detect it by tau PET. So this slide is a little bit old. Amyloid PET and amyloid and the CSF test for amyloid are FDA approved, and Medicare and other insurance companies cover the cost of those tests. Right now, the cost of those tests, you can get the spinal fluid tau for free, because when you get the amyloid, you also examine for tau, so there's no sort of extra charge for that as it were. But the amyloid, the tau PET scan is not currently covered by Medicare or insurance companies. So it's really only done in the context of a research study, where the cost will be paid by the research study. And then we can assess neurodegeneration to some extent by MRI, so a structural MRI. So then we look at the brain and see that, and the neurologist or the radiologist may say there's been some shrinkage in the brain. And they can quantify that shrinkage, and they can also tell you the shrinkage is in one area or another area. For example, if it's more in the medial temporal lobe, that raises the suspicion of Alzheimer's disease. If it's more in other regions, it raises suspicions of other diseases. So this is the amyloid cascade. And the reason why I wanted to spend some time on this is because I'm going to come back to this in the end in terms of treatment. So the amyloid cascade hypothesis, according to this, amyloid is the first thing to go wrong, at least that we can tell. There's probably things that are going wrong before that, but we can't tell them yet. And then tau, and then neurodegeneration. So the thinking then in terms of treatment, and people have been working on this for about 2 decades, is that if we can somehow detect the amyloid in the brain very early and clear it by some treatment, then maybe we can slow the progression of Alzheimer's, and if we're lucky, maybe even arrest the progression. And I'm going to talk about this towards the end of the talk. The FDA has just approved 2 medications that do exactly that clear the amyloid from the brain, and there's been modest clinical benefit as a result of that. We'll talk more about that in a moment. Any questions so far? Is it clear? I'm not losing everybody. Like I said, don't hesitate to ask questions. Yes?
Does amyloid, that's totally a bad thing? You don't need that for anything?
Good, very, very good question. No, amyloid is a normal protein. We need it for normal things. But what happens here is that this misfolded form creates a bad, it's like, it creates a bad version of the amyloid.
Okay.
And that's what's the problem. But amyloid is very important. It's actually important in what we call synaptic function, the signaling from neuron to neuron. That's a very, very, very good question. And why exactly this transformation happens, we don't really know. Okay, there are a number of risk factors for dementia. And this is something that your family physician can help you check for. There are some genetic risk factors. Probably only about 5% or so of Alzheimer's disease, for example, is caused by genetic factors. And then there are also what we call modulatory risk factors. That is, there are some particular genes that can increase your risk without actually contributing directly to the pathology of Alzheimer's. The vascular risk factors that we are all pretty familiar with, that your physician is checking you very regularly for: high blood pressure, diabetes, high cholesterol. These are all risk factors for vascular disease. They're risk factors for heart disease, for heart attacks, they're risk factors for stroke. Turns out these are also risk factors for Alzheimer's disease. So this just sort of underscores how little we actually understand about the pathology. How we get from these risk factors to the disease, still mysterious. But it's really important, we'll come to this in terms of prevention, to make sure that we test for these risk factors and try to control them to the best of our ability. And we have very good ways to treat them. Yes, Rob?
In terms of prevention, I guess it's pretty obvious from my standpoint, because I come from a wellness fitness perspective.
Yes.
That sustaining good vascular flow
Yes.
is the best prevention that someone can do along around. Is that correct?
Correct, and we'll come to that in a moment. I think the next slide or two, we've got a slide on risk factors. Yeah.
I was peeking at your slide there.
Yeah, absolutely. So that's great.
Yeah.
It's great that you're thinking that way, because that's exactly where we're going. Head injuries, especially severe head injuries, can be a risk factor for dementia in later life. How exactly, we don't really know, but maybe it starts that amyloid cascade going a little bit earlier or a little bit faster. Sleep apnea. Sleep apnea is very common. It's estimated that about 10% of the US population actually has sleep apnea. Sleep apnea means that when you fall asleep, there are in certain cases, your airway tends to collapse. And then as a result of that, you become apneic, that is, you stop breathing for some time. And then the signals get to your brain, and then you start breathing again, kind of with a gasp. It's very difficult for a person to know if they have sleep apnea or not. Usually their bed partner is the one who knows if they have sleep apnea or not. But if there's any suspicion, And it's more common in people who gain weight. Not only, but is more common in people who gain weight. So that's something that is necessary to screen for. Sometimes you have to have a sleep test. Typically, people with sleep apnea don't sleep very well at night. They think they sleep well, but they don't actually sleep well, and so they have a lot of sleepiness during the day. So that could be sort of a signal that you might have sleep apnea. Another signal is that you might wake up with morning headaches, and you do that on a regular basis with morning headaches. That might be a sign that you have sleep apnea. You might want to go to your doctor and get checked out, and maybe have a sleep study. There are now studies that you can do at home. They're not as good as what you can do in the sleep lab, but your doctor can help you with that. And then depression. Depression is a very, very important risk factor. There have been good studies now showing that depression in, say, midlife, say maybe in your 40s or 50s, can be a risk factor for dementia a couple of decades later. So identifying and treating depression is very important. And depression is, again, one of those things that's not necessarily very obvious to everybody and may not be the easiest thing to diagnose. And it's like anything else. It's a medical disorder, should be taken seriously, and we have pretty good treatments for it in most cases. The other thing that's potentially complicating is that depression alone can cause what we call pseudo-dementia. That's not true dementia, but as I said earlier, as a result of depression, you might have trouble with memory. You might have trouble with executive function. And then when you're tested in the office, you might be shown to have objective deficits in memory and executive function and so on and so forth. But maybe there's no neurodegeneration going on. It could be just pseudo-dementia. So sometimes we see a patient like that, there's prominent depression. What we try to do is we try to make sure that depression is treated as well as possible. And then sometimes, the symptoms get better. So then we know that it is actually pseudo-dementia. Yes?
Is there like a definitive way to test for amyloid plaques in the brain, or is it all based on cognitive testing?
So as I said here, there are two ways actually we can identify amyloid, the bad amyloid in the brain. One is by spinal fluid,
Spinal tap?
CSF, what I call it, that's cerebrospinal fluid, spinal tap, you get the spinal fluid, and the other is what we call amyloid imaging, a special kind of PET scan that shows you the presence of amyloid in the brain. It's an expensive scan, but it's now covered by Medicare if there's an indication that you might proceed to treatment with anti-amyloid therapy. We'll come to that in a moment. And I'll be reiterating all this in that context. There are a number of protective factors as well. Again, genetic, there are some genetic profiles that are risk and other genetic profiles that are protective. For example, there's a particular gene for a protein in the blood called apolipoprotein E, long name. So we usually abbreviate it as ApoE. And the short version of the story here is that if you have the E2 allele, so everybody's got two alleles for a particular gene, one from the dad, one from the mom. So if those two are what we call E2, those are actually protected. If you have E4, those are actually risk factors. And two E4s is worse than one E4. And if you have E3, that's neutral. So we can actually test for this, and that can give you some idea of your risk for Alzheimer's disease, although it doesn't really, it's not diagnostic, but it's one of the things that we do in the context of treatment as well. Education, as well as bilingualism, what they tend to do is they tend to delay the onset of the disease. If you remember that curve from this curve here, so it gives you a higher cognitive reserve. So the pathology might be accumulating in your brain at the same rate, but you don't go into MCI here, you might go into MCI here, and you might only go into dementia here. So they are protective in the sense that they would delay the onset of the disease, but so far they don't actually seem to enable you to not get the disease. A Mediterranean diet, again, so we can see sort of, this is a foretaste of the things that we can do to prevent dementia. And physical activity, as I think Rob was alluding to earlier. So, this is a slide I wanted to spend some time on. This is perhaps the most important slide in the talk. What can we do to prevent cognitive impairment? And some of these studies, some of these items are backed by extremely good data, and others not so much. Probably the biggest impact, the intervention with the biggest impact is exercise, physical activity. And there's a lot of data by this, a lot of data supporting this, and the effect size, what we call in statistics, the effect size for this is huge. It's a very big effect size. So I tell all my patients, every encounter I have with a patient, I reinforce the value of exercise. Aerobic exercise, at least 30 minutes, and if you can get to 60 minutes a day, that's great, 5 days a week. So the American Academy of Exercise Medicine recommends 150 to 300 minutes of aerobic exercise per week. What's aerobic exercise? Just walking is good. If you can do a brisk walk, think about trying to do 2 miles in 30 minutes. And like I tell people, don't worry if you can't get to that goal. It's better to do some than none. Something's better than nothing. So any amount of exercise is good. The only thing you've got to be careful about with exercise is, not to fall, not to injure yourself. So if you've got balance problems, that, walking is going to be difficult, but somebody like Rob can help you figure out what's the right form of exercise for you. You can get on a stationary bike, you could use a treadmill with support, elliptical machine, rowing machine. Basically what we're trying to do is we're trying to get your heart rate up and keep it up for that period of time. And the number of benefits this has for your life are so many that we could have just a whole lecture on that. Because what exercise seems to do is it releases what we call mediators, a lot of the body's natural molecules. You may have heard of things like endorphins, endocannabinoids. The reason why morphine-like drugs work for pain is because they actually tap into receptors that the body has for morphine-like substances that are produced in the body at very, very small micro levels. And similarly, that's why cannabis works as it does, because it's tapping into these endocannabinoid receptors. So it liberates all these things, and it liberates maybe 1,000 different molecules. And they all have beneficial effects. The way I like to think about it is, we think of early humans, early Homo sapiens evolving. So Homo sapiens, we think, has been on this planet for about 200,000 years. That's all. Our ancestors were hunters and gatherers. And they had to go long distances to find their food, whether the men went to hunt or the women went to gather fruits and nuts and seeds. They had to go long distances. And then they had to find their way back through environments that were pretty similar. So that's kind of like hippocampal, using your memory system, stimulating neuroplasticity. So we had these systems co-evolve for fitness, physical fitness, as well as brain fitness. And of course, you all know that this exercise is very good for your heart, as Rob said earlier, for your vasculature, your blood supply to the heart, to the legs, to the belly, and to the brain. It's important. Exercise is also very good antidepressant. There was at least one study done where exercise turned out to be as good as Prozac for treatment of depression, at least mild depression. So, it can help you with your mood, and then it helps you with your balance. There's just so many things of it. We all should be doing a lot more exercise than we actually do. The second thing for which there's a lot of data for is Mediterranean diet. What's a Mediterranean diet? You can Google it, but very briefly, a Mediterranean diet it's how people eat who live around the Mediterranean Sea, right? And their diet really consists of whole grains, fruits, and vegetables. That's the bulk of your diet. So whole grains, we're talking about, simply substitute brown rice or brown bread for your white rice and white bread. Things like quinoa are rich in fiber. There are whole grains. There are a few whole grains like farro. So these are some examples of whole grains. But the fruits and vegetables, you have plentiful produce available here in the Central PA, and that's the bulk of it. And I think the beauty of the Mediterranean diet, why it works so well, this has been studied in multiple studies across the world. Why it works so well is because you have so much choice. You can tailor it to your own taste, your own preference, and you can still find plenty that you like. The big point of departure, as I say, from between the Mediterranean diet and the standard, perhaps Pennsylvania diet, is the red meat. In the Mediterranean diet, red meat is consumed hardly at all, maybe once a month if that. But what I tell people, just like with the exercise, something's better than nothing. If you're here on the Pennsylvania diet and you want to go to the Mediterranean diet there, don't try to do that overnight. Make your adjustments slowly. Wean yourself off the red meat. If you're going to eat red meat, try to make sure you're eating a lean cut, because you want to really try to minimize the animal fat. That seems to be what's not good in you. You can eat fish as much as you like. Meaty fish like tuna and swordfish can be, can sort of satisfy that craving for meat. But you don't want to eat too much of those fish because they contain high levels of mercury. So not too much of them per month, right? Chicken, poultry without the skin as much as you want. So there's things that you can do there. Fats are really coming from things like olive oil and nuts and so on. Regular sleep is really important. So going to sleep at a regular time and sleeping well is really important, because one of the things that's been shown recently, we're probably going to see a Nobel Prize awarded for this, is that during sleep, in the particular stage of sleep that we call slow wave sleep, the vasculature in the brain, the blood vessels in the brain, go into sort of massive pulsations. And those pulsations appear to be driven by the slow waves, electrical waves of the brain. And those pulsations seem to be very important in clearing that amyloid and other proteins from the brain. So that regular sleep is really important. That's, again, goes back to sleep apnea, why we need to diagnose that, or any other sleep condition. If you're not sleeping well, you really need to talk to your physician and find out how you can sleep. One of the things that exercise does is it actually helps you sleep better. If you're physically tired, you're more likely to sleep better. Cognitive activity, not so much data behind this right now, but it makes sort of sense in terms of promoting neural plasticity. The brain's, I always say, the brain's like a sharp knife. If you don't use it, it gets rusty. So use it or lose it. Right? So keep your brain active and socialize. Socialization is very important. Oftentimes what happens to an elderly person who loses their spouse, for example, they may withdraw and have less social activity, and that can be detrimental to brain health. So cognitive and social stimulation is recognized to be vital for preserving brain health. As I said, head injuries can be a risk factor for dementia, so make sure you use those seatbelts. Even if you're sitting in the back seat. Some people say, I'm sitting in the back seat, it doesn't matter, but you can get injured there. So prevention is better than cure. Yes, Rob?
In terms of competency when driving, when you get older,
Yeah.
it is very unsafe for
Exactly.
someone to be on the road that shouldn't be.
Yeah.
Is there any cognitive assessments or tests out there that can be given to an older adult just to create an awareness of whether or not they're cognitively prepared for the demands of driving, especially peripheral vision,
Yeah.
that type of thing? Is that something that's
Yeah. So that's a very good question. So in the neurologist's office, what we'll often do is how we sort of test for that is testing executive function. And there's a particular test that we use of executive function where you have to sort of switch between different tasks. And usually if somebody fails that task, it's an indicator that maybe they shouldn't be driving. So we usually have a conversation with the patient and the family at that time, and then have them start thinking about it. Interestingly, many people with mild cognitive impairment will themselves decide not to drive. But sometimes we have to have that conversation. You can also have a formal driving evaluation where you actually sit in a driving simulator and they put you through your paces as if you were on the road, and they can evaluate things like the speed of your responses. I tell people sometimes it's not really about the mechanics of driving so much, but you just have to multitask. People do stupid things on the road, and how do you react to that? Can you react fast enough? And so usually we have that conversation in terms of safety. Yeah.
And is it available at the PCP level? I know you're a specialist, but would a PCP be able to do some of those cognitive tests?
Yeah, this is really, really important, really good question, because honestly, there's not enough neurologists and neuropsychologists for the demands, right? Yes, but so one of the tests that we do is called the Montreal Cognitive Assessment. It's called the MOCA. Takes about 15 minutes to administer in our office. It's administered by a medical assistant. So PCPs often use a different test called the MMSE, the Mini Mental Status Evaluation, which is not as sensitive. But if they use the MoCA, there's one test on the MoCA that actually indexes that. So if they use the MoCA, they could do it. So one of the things that we try to do is, that as we interact with PCPs, we try to encourage them to use that test rather than this, because it's a little bit more sensitive. Great questions. Yes?
Can you comment on the effect of sugar in a diet?
Yeah. So that's a bit of a complicated thing. So sugar, some sugar is okay. But one of the things that we talk about with the Mediterranean diet is really we are biasing towards whole grains, complex carbohydrates. So the more you consume your carbohydrates in the form of complex structures, like in fiber, the better. So a little bit of sugar is okay, and I usually tell people, have those desserts, that ice cream, as a special treat. Don't have it for lunch as well as dinner every day, because really that can cause a lot of problems. So the brain is very, very sensitive to glucose. Now it needs that glucose in order to function, right? But if the level of sugar in the blood is too high or too low, the neurons don't function optimally. And so what happens when you consume complex carbohydrates is those get broken down in the gut to some extent. Some of it is not even absorbed, but the part that's absorbed gets broken down bit by bit. And so what happens is then you get a very slow increase in your blood sugar after a meal, and then your insulin kicks in, and then it comes back down to normal. If you consume sugar, what happens is you have this big spike, it goes up, then it comes right back down, and so then you have these wild swings, and it's much harder for your brain or the rest of your body to adapt to that. Very good question. Did I answer your question? Still a little puzzled. Okay, we can talk more. And then early diagnosis and management of risk factors. So this is what your PCP is doing all the time. Trying to get those vascular risk factors under control. Do you have high blood pressure? Do you have diabetes? Do you have high cholesterol, or for that matter, high triglycerides or whatever? And if you do, we have really good medications now that can get these under control. And of course, I always tell people, if you do that exercise, maybe if you're sort of got mild abnormalities in each of these, exercise might be enough. Exercise in the Mediterranean diet can control that. And then identifying depression and treating it, identifying sleep apnea and treating it. So this prevention of cognitive impairment, we can't emphasize enough, because there's so many things that go into it. If we can do at least the exercise, the Mediterranean diet, regular sleep, and then your physician can take care of these things, and you take care of the cognitive and socialization. Wearing seatbelts is easy. So these things are, should be relatively easy to implement. If we are able to implement this at a population level, you're going to see a dramatic improvement in that. Because we all have finite life, right? But what we want to do is, the time that we're here on this planet, we want to make sure that we can be as happy as we can, as socially engaged as we can, give back as much as we can. In order to do all that, we need brain health. So that's what this is all about. Just going to go rapidly through a few of the diagnostic tests. This is really perhaps more important for physicians, but I just want to underscore again that this diagnosis might be uncertain in life. Your physician will talk to you, it's a neurologist or psychiatrist or PCP, geriatrician, your neuropsychologist in some cases. They take a history, talk to the patient. This is kind of, I'm working with my residents now to sort of re-educate them on the importance of the medical history. Just talking to the patient. Because residents, they love to look at the MRIs before they want to tell me about the MRIs. I say, no, I don't want to hear about the MRIs. What did the patient say? What's the problem? And I tell patients, we don't treat your scans. We don't treat your lab tests. We treat you. That's what we're trying to do. So things like this, when did the symptoms start? What was the time course? And that can be helpful sometimes. For example, if there's early and isolated memory loss, that's pretty typical for an Alzheimer's picture. If there's early changes in behavior or changes in language, it's more commonly FTD, frontotemporal dementia. If there's difficulty with REM sleep, dream sleep, people acting out their dreams, that's what we call REM behavior disorder, or prominent visual hallucinations during daytime, that may suggest Lewy body disease. Sometimes you have this phenomenon of an alien hand, that's your hand's going off by itself and doing things that you didn't want it to do. That's called an alien hand. It's as if you're controlled by an alien. That can occur in this particular disorder, corticobasal ganglionic degeneration. So there can be clues on the history to the diagnosis. And then we do a careful neurologic exam. And again, there's a bunch of things that we can do that may suggest specific problems. Not going to dwell on that. We can do some blood tests, and this is important because what we're doing with these blood tests to rule out mimics. So a person may come in with cognitive impairment. So it happened actually to my aunt. She was in her 50s and she had like florid cognitive problems and she was having psychiatric problems. Turned out that she was deficient in vitamin B12 and her thyroid was not working so well. So thyroid problems, either if it's hyper or hypo, overactive or underactive, can mimic cognitive, it can cause cognitive dysfunction and look like a mild cognitive impairment. Vitamin B12 deficiency can cause this. Syphilis not so common anymore, except in certain populations. That can also cause dementia. So the importance of that is identifying and treating those, so then we're sort of not in the dementia spectrum. And then of course we can do tests for these genetic risk factors, and the blood tests for specific biomarkers for Alzheimer's are still being evaluated. Probably in a few years, I don't know, maybe 5 years, we'll be doing routine blood tests that will help us diagnose Alzheimer's disease. So that's when the PCP will really be able to do that. But they're not ready for prime time at this point. Neuroimaging, Dr. Moshe's specialty is not neuroimaging specifically, but radiology, very important. MRI, and we have different field strengths of MRI. It's quantified in terms of Tesla units. So the higher the field strength, the sharper your image. As I said, you can see the shrinkage, technically we call it cortical atrophy. Is it diffuse? Is it one area versus another? We can actually quantify the volume of the hippocampus. That can be helpful for diagnosing Alzheimer's. If there's microvascular disease, we identify this by what we call white matter changes. You may have heard of that. And then there's this entity called normal pressure hydrocephalus, which can also cause dementia. PET scanning, as I said earlier, this is called a metabolic PET scan. There's some regional variations in there that can be moderately helpful in distinguishing, for example, Alzheimer's from frontotemporal dementia. But really now amyloid PET is the new kid on the block. We're actually using this regularly for diagnosis of Alzheimer's in addition to the spinal fluid. And tau PET, as I said earlier, is a research tool. So, and then neuropsychological testing is very important because we can have these short tests, like I said, the mini mental status evaluation or the MOCA, the Montreal Cognitive Assessment. These are just short tests, 10 to 15 minutes. You can do an hour-long battery or sometimes just a variety of tests that can take hours to do. And those can be helpful in determining the profile of cognitive impairment and helping to make a diagnosis. We can examine the spinal fluid, and if there's a specific pattern in the spinal fluid, your beta amyloid is low, your tau is high, and your phospho-tau is also high, and they cross certain thresholds, the labs will report that to you, and you can make a diagnosis, a confident diagnosis of Alzheimer's disease in life, either from this or from the amyloid PET scan that I talked about earlier. And there's a variety of treatments. There are some symptomatic medications that we use that can help support memory. These are called, examples are, you may have heard of Aricept or donepezil, Namenda or memantine. One of the things that we do that's very, very important is to look at the medication list. Because doctors have a habit of adding medications onto your list, right? Nobody ever takes them away. So one of the first things I do is to look at what medications are you on. Do you still need those? Maybe those medications were started 10 years ago for a good reason. Maybe you don't need them now. Can we take them off? So that kind of conversation. And usually we don't do things willy-nilly. We engage with the primary care physician and discuss these and try to see what are the medications that we can take away. Especially, for example, some medications that are used to treat bladder dysfunction can impair cognition. So that's a problem. So we may want to have a discussion about that. Medication that can help with sleep. We prefer to use something called trazodone because it doesn't really have a hangover, doesn't cause doesn't cause addiction, but there are many other things that you could use. Treatment of depression, managing the risk factors, and then recommending the things that we talked about earlier, exercise, cognitive stimulation, the Mediterranean diet should be here as well, the formal cognitive rehab. For patients with mild cognitive impairment, we can actually improve their function by engaging them in a formal program of cognitive rehab. We've done some research in this area, and so that we actually did a clinical trial there, and that can be beneficial. And of course, social support is very important. In the last couple of minutes, I just wanted to make you aware of these new cutting-edge treatments for Alzheimer's disease. This is founded, as I said, on the idea of the amyloid cascade hypothesis that I described earlier. If amyloid is the earliest change that we can detect, maybe we can clear the amyloid, and that'll be helpful. So after a lot of research and a number of failed clinical trials, these two agents are monoclonal antibodies to amyloid that were developed, and these have actually they had successful outcomes in clinical trials, and they have both been FDA approved. Lecanemab was approved about a year ago, and donanemab was just approved like a couple of weeks ago for treatment for Alzheimer's disease. So what these do is these monoclonal antibodies target various forms of the amyloid in the brain and then clear them out of the brain. And they're very, very effective at clearing them from the brain.
Can I ask a question about that?
Yeah.
What about the side effects of those? I know that was very
Important side effects. Very, very good question. I'm going to talk about that.
Thank you.
Yeah. This is not by any means a very simple discussion. It's a very complex discussion here. So the first thing I want to mention here is that the agents do a very good job of clearing the amyloid from the brain. So if you are, this graph shows that the amyloid in patients who got the placebo stays the same, in terms of the PET scan. But if you use this agent lecanemab, that amyloid is going almost to zero. So more than 80% of the amyloid is being cleared from the brain over the 18 months of the study. The clinical benefit, though, it's measured by this score here. I'm not going to go into the details. Clinical benefit is modest. It is not the earth-shattering, result that people were hoping for. But there's a modest clinical benefit in that the patients on the placebo got worse. Patients on the drug also got worse, but not as much. So they're a little bit better at the end of 18 months than they were, start. So, and so you can see that, almost 80% reduction in the amyloid, but, maybe 25% reduction in the slowing of the reduction of cognitive decline. Similar results with the other agent. I'm not going to go into the details of that, but again, does a very good job at clearing the amyloid. Very similar, modest clinical benefit, maybe slightly more effective. Look at the numbers, just a little bit higher. But and in this study, they looked at patients who had high tau, as well as low or medium tau. And the patients with low or medium tau seem to do better. So it kind of fits with that idea that the earlier in the game you start this treatment, the more likely you are to be successful. But we have side effects. Also, it's not easy to administer these medications. It's kind of a pain. You have to give IV infusions at an infusion center, intravenous infusions, every 2 weeks for one of the drugs, every 4 weeks for the other drug. You can get some infusion reactions. Usually these are, not major. You need a bunch of MRIs. You need MRIs before you start treatment and then at regular intervals. So if for some reason you cannot have an MRI, then you really can't have this medication. Also, because of the side effects, which I'll come to in a moment, you need very careful monitoring at home by your caregiver, your spouse or other family member, and by your physician. So for a single person living alone, whose family is far away, they are not really ideal candidates for this medication. So we have to have this discussion with patients and their family, and really it's the patient's choice as to whether they want to elect the medication or not, especially given the side effects. The two main side effects, the side effects are, euphemistically called ARIA. Nothing to do with an ARIA, but it stands for amyloid-related imaging abnormalities. So basically the main point here is that you can either get brain swelling, as shown in this MRI, or you can get bleeding into the brain. These are the two main side effects. So these are high risks, these could be severe. So the idea here is that if you keep doing these MRIs regularly, you can detect these early. In the studies that were done for lecanemab, the first medication, nobody died in the study. About a quarter to a third of patients experienced these side effects, but most of them were asymptomatic. That is, they didn't have symptoms, they only found incidentally on the MRI. In the other drug, the second drug, donanemab, which as I said is a little bit more potent, the actual effect of it is a little bit more. The side effects also seem to be a little bit more. And 3 patients actually died in that study. So we talk to patients about this risk-benefit analysis. And very frankly, my patients fall into 2 groups. I tell people that, it's your choice. Some people say, you know what, I'm doing fine right now. I don't really feel like intervening and incurring this big risk for a potentially modest benefit. And other people say, no, I'm getting worse, so I'd really like to see if I can do something about it. So it's really their choice. And then we support them in that choice, and then we monitor them regularly. We have a number of patients now on that first medication, and so far, they do okay. And there are a bunch of prerequisites, like I said. Yes?
But are they looking at having these infusions?
Yes.
Over years and years and years?
So far as we know, we don't know exactly, in the second study, for the second drug, they actually stopped the medication after the amyloid was cleared from the brain. In the first study, they didn't do that, so maybe that's what we'll end up doing. Will the amyloid eventually build back up, and then we have to start treatment again? We don't know. But good question, yes?
If you go back to the graphs, I look at those graphs and say, well, yes, it really took the amyloid out of the brain,
Yeah.
but there wasn't that much difference.
Correct.
So the amyloid might not be the problem.
Very good point. Exactly what many people are saying. It might not be the problem. Maybe the amyloid cascade hypothesis is not completely correct. But this is for us in the field, this is game-changing in the sense that this is the first disease-modifying treatment that we've had. Think of it in terms of treatment of cancer. When the first agents came out, they weren't very good. There are a lot of side effects. But now we've come a long way from there, we can actually cure some of these cancers. So we're in the early stages, as I say, where this is not the end. It's not even the beginning of the end, to quote Winston Churchill. It may be the end of the beginning.
Well, in those studies, did they change their lifestyle as well?
No, they didn't really do that. Good questions, can we do more? Would we have a better effect? If we did rehab on top of that, would we even do better? So we have some ideas about studies like that. So I think we're almost out of time here, so I'm glad we had a bunch of questions. We have people with certain medical conditions. For example, if you have high likelihood of having stroke, you don't want to increase the risk of brain bleeding, so we might not want to provide these treatments. So there's various things that we have to make a diagnosis of the Alzheimer's by biomarkers before we can actually provide it. And there are a few other considerations, some of which we've already talked about. There's slowing of disease progression. You're not going to actually improve cognitive function. As we said, it's unclear if we continue the treatment beyond 18 months of the clinical trial, whether we will continue to see improvement or not, which medication should we use now. And one important thing here is that in these trials, there were very few minority participants, so we don't know if these findings will necessarily generalize to other populations. That's what I wanted to share with you this morning. Thank you for your attention. You've been a great audience. Yes.
For patients that have a clear family history, are you recommending they do genotyping now, or is it still up to the patient and family?
Well, it's really up to the patient and family, and in some cases their insurance company as to whether the cost will be covered.
Because you might find out, certain members of the family have a risk factor, others don't.
Yeah,
So
the genotyping.
It's a hard controversy.
It's a good question. I mean, the only thing that we're actually genotyping for is the ApoE, polymorphism. And that's helpful to some extent. The reason why we do that for this particular treatment is if you have, like I said, the bad ones, the E4s, that increase the risk of bleeding. That's why. So, yeah. But otherwise, we don't do it routinely. There are some studies ongoing where there's a very strong family history. If it's genetically inherited Alzheimer's, those people will tend to have mild cognitive impairment by their 30s and dementia in their 40s. So there's a study out of WashU which is looking at those people where you know that they have the gene. These are mutations in specific proteins, and then they're trying to identify very early what we might be able to do. Yes.
What relationship might there be between cognitive impairments and, say, eyesight?
Eyesight?
Yeah.
That's a good question. There's been some speculation that Alzheimer's disease is similar to macular degeneration. So macular degeneration is associated with formation of, abnormal clumping proteins in the retina. The retina is actually part of the brain. The retina, the back part of the eye, is actually part of the brain that during development went out and got situated in the eye. So eye disease can often be an important window into the brain. The other thing is, if you're sort of losing memory or having trouble with executive function, one of the things we want to do is we want to make sure that the sensory function is optimized. So we want to make sure that people's vision is good, and also very importantly that their hearing is good. One of the sort of really treatable risk factors for dementia, I didn't talk about here, is hearing loss. So we want to test for hearing loss and get a hearing aid that works and the patient can accept and wear, and that can be very helpful, because otherwise you sort of get into this vicious cycle of sort of withdrawal. Yes?
Are there physical symptoms? Do people ever have physical symptoms like
Yeah.
their gait being
Good
off?
question,
They're,
yes.
uncoordinated?
Correct,
or
yeah.
headaches or something?